very small topics, that is amyloidosis. It is what is this thing? Amyloidosis is a group of disease which are produced by depositions of proteinous material in between the cells or extracellular space. So these are typically insoluble proteins that are deposited in between the cells, not between the cells or extracellular space, and produce the disease. So it is a group of disorders where proteinous material that are deposited in between the cells and the tissue produce the disease. And the substance that are deposited is called amyloid, which has common morphological appearance, physical appearance, and the staining properties, but they have separate biochemical entities. So these are the common features of morphologically, staining properties, and the physical nature. They are common, but they are different between the chemical properties they have different. This is the properties of an amyloid, and it is derived from that word amylon in a Latin word, and the amylon from a Greek word, as it is a starch-like material. Because first when they discovered this thing, it is after application of the iodine and the disulfuric acid, they produce a blue color. So this will look like a starch-like material, and you will say it was called, it is a starch-like material, and it is called amyloid. And from the history, that Pharmacology 1842 first it is described this entity as a starch-like material. Afterwards, that Westow in 1854 he only described that it is a starch-like material. But after 5 years, Edul and the Fredericks they discovered that it is not the starch-like material; it is a proteinaceous in nature. So, it is an amyloid. How it is formed and why it is identified as a disease that produces, from where is the source? Normally, the protein that is identified as a folded, it is a folded protein where they are synthesized. But afterwards, to produce a structural entity, it becomes folded and structural form to become active. But if it is happened, this folded one become misfolded. And that system they will try to disintegrate for their normal function. And in the system they disintegrated with a misfolded protein. But if it is occurs, the misfolded protein is improperly degraded in the system, they are, if it is improper, they are deposited in these cells. Now in between the cells, not within these cells, as a proteinaceous material, that is amyloid. So this is the entity from how it is formed. The protein normal is a structural protein. They are folded, sorted, structured, become active. But whether it is misfolded, that is not arranged properly, misfolded one, in the system, they are degraded improperly. They are degraded protein deposited in between the cells and tissue as amyloid. So this is the source of that protein. They are deposited in these cells and between the cells. So what we have to learn? Amyloidosis we have to learn for exam point. That's a definition. Their physical properties, their chemical properties, their pathogenesis, how they are formed, their classification, morphological characteristics, and their staining properties and diagnosis. The exam can become splitted form. But maybe a definition, maybe a pathogenesis, maybe a classification, maybe a diagnosis, maybe a morphology, whatever, and the diagnosis they can ask in the exam in the splitted form. So we have to learn, not go in details, not go in the molecular level. For exam purpose, you spend that time only, not go in deep. So we learn today for exam point of view. So amyloid, it is how it is formed, is the result from an abnormal folding of the protein. Normal protein, they are formed normally for structural one and for their function. But when they are folded abnormally, which become insoluble and aggregated and deposited as a fibrillary form in the extracellular space that I told. And normally this misfolded protein, when they form, proteasome within the cell and outside by the macrophage. They are degraded normally. Then if it is formed within the system. But if not degraded or degraded improperly, they are deposited as a regulatory protein called amyloid. How they are formed? What is the aggravating factor for this is sometimes they are normal protein. If it is formed abnormal amount, they will not degraded properly. So they are deposited. Or protein they have mutated form. Sometimes they are acquired mutation, maybe hereditary mutation. That mutated protein they are not functioning properly. They are degraded not properly as they are deposited and misfolded protein within the in between the cells and the tissue. And sometimes that aggravating factor may be muted, maybe hereditary mutation, maybe acquired mutation. They are not properly degraded, so that protein also acts as an amyloid fibrillary protein. And sometimes there are the improper degrading protein degradation. They also can deposit. So normal protein in abnormal level they are secreted, they are deposited. If it is improperly degraded, or maybe mutation, or maybe defective degradation, they are the cause factor. They are responsible for the deposition. So now the character. What is the character? All the amyloids are same morphological character, physical character, and staining properties are common, but they are different in chemical natures and how they form. So they are different in chemical nature, but the same morphological structure, physical structures, and the staining property. This is the characteristics of amyloid. Now, all the amyloids show, that is the very important thing. They will ask in the exam, in the oral, all the amyloids are component positive. After that, if we put it under polarized light, they will inform the apple green binary. So, this is the characteristics of an amyloid material. What is that thing? All the amyloids are component after component staining. If we put under polarized microscope, they will indicate an apple green binary. It is the characteristics of all the amyloids, but are chemically different. So only one thing different is the chemical nature and source of production. They are different, and the common physical character, morphological character, and staining property. So this is that's all about amyloid. Clear? Next, what is the physical nature? Physical nature of the system all are common. They are fibrillary proteins in non-branching fibrillary continuous protein with 7.5 to 10 nanometer in diameter. This is non-branching, and they have a characteristic beta-pleated sheet. These are the beta-pleated sheet and responsible for this congruent staining and apple-green birefringence under polarized light. Why it is produced? Due to this characteristic beta-pleated sheet of this configuration. The physical nature, these fibrillary materials, they are arranged in a beta-pleated sheet. When they are misfolded, they produce a beta-pleated sheet, and for this configuration, if we put under polarized light after congruent staining, they produce apple green birefringence. This is the characteristic of all. So if the material is amyloid, if we put under HNE stain or hematoxylin stain, they are eosinophilic in nature. But under polarized light, they produce an apple green. This is the apple green birefringence after congruent staining. This is the characteristic. You have to know that thing. The only one thing is the after congruent staining, if we put under polarized light, they produce an apple green birefringence. Why it is produced? Due to this characteristic beta-pleated characteristic physical nature of that. Clear? Now chemical nature. So definition we know, then physical character we know. Now it is the chemical nature. I told you that different chemical characteristics. So what are those things? They have fibrillary protein is 95%, some pockets will get 90%, and non-fibrillary material is the 10 to 5%. That is the P component. And the fibrillary components are A type or amyloid light chain protein. The chemical nature, one is AL, one is A, amyloid associated protein, then beta amyloid protein, transthyretin, TTR or transthyretin, Then beta 2 microglobulin, prion protein means protein that deposited in the CNS and the endocrine associated amyloidosis. So this is the chemical nature. So they are different. AA type, AA type, then beta amyloid, beta 2 microglobulin, transthyretin, prion protein, and endocrine associated amyloidosis. So here too, there are several types of chemical nature, but only for exam purpose you know only this much only. That is enough for you. Not go to the details. Now how they form? So their formation is different. Chemically different, their nature is different, and their formation of that type of particular they are also different. First one is the AA type, amyloid light chain type. How they are produced? Amyloid light chain, that is the immunoglobulin chains. Sometimes are plasma cells, they are terminally differentiated cells of beta lymphocyte, B lymphocyte. They are terminally differentiated from the plasma cell. If it is a lymphoma, that is the multiple myeloma, plasma cell dysplasia, this mutation of these plasma cells, they are produce enormous production of the immunoglobulin by plasma cells. And when these immunoglobulin either kappa or lambda, they are incorporated, disintegrated in the system, they are deposited in the different sides of the body. So it is a type of AA type of amyloid light chain proteins. That's the one amyloid. Next one, AA or amyloid associated protein. How they form? Usually, if it is under chronic inflammation, any infectious disease, there is activation of cytokines by the liver. SAA, serum amyloid associated protein. They are secreted by the liver, by the influence of macrophages IL-1 and IL-6. They are activate the liver to produce this normal protein SAA, serum amyloid associated protein. If this thing is incompletely disordered, it produces enormous amount. This amount, this normal protein, but it is an abnormal amount they are produced. They are deposited, if not completely disintegrated from the system, they are deposited in the tissue, in between the cells and the connective tissue, not within the cell. If it is a cell, they are proteasome, they disintegrate, but outside the macrophages, they will disintegrate. So if it is excess, they are deposited as AA or amyloid associated protein, and the precursor protein is SAA, serum amyloid associated, secreted in the liver into chronic inflammation. Next one is the beta amyloid protein. That is the cerebral plaque. This protein is found in the cerebral plaque and blood vessels and produce an insoluble form of that amyloid in the CNS structure. Next one is the transthyretin, TTR. Normally they are produced transthyretin. That is the carrier protein which carries the thyroxine and the retinol as a carrier protein, transthyretin. If it is produced an enormous amount, they are not completely disintegrated, they are deposited in the system, that is as TTR, and that the protein is called ATTR, that is the amyloid plaque. So these are the distributed, the source of production is like that, and they are insoluble in the protein and deposited within the tissue. Now beta 2 microglobulin, another type of amyloid. What is that amyloid? This amyloid is a that is the MHC class 1 molecule. And this is a beta 2 microglobulin. It is a component of MHC1 molecule. If it is a chronic renal failure, the patient having the frequent dialysis, they are not cross the dialysis membrane. So they are circulating in the system is enormously. So they are deposited in the joint area as the beta 2 microglobulin. So patient having chronic renal failure needs the dialysis frequently. So these proteins may not cross the dialysis membrane and circulate enormously and deposited as a molecule joint area as amyloid beta 2 microglobulin. Another two is the prion protein, that is also a misfolded protein. You know the prion disease, the protein just from the prion disease, they are deposited in the cerebral plaque as a prior associated amyloid. Another one is the endocrine associated pancreas, thyroid. These are the endocrine gland. They also deposited this amyloid material within the endocrine gland. That is the tumor producing from the thyroid. That is the medullary parts of the thyroid. They are deposited and amyloid in the thyroid. And pancreas, the islets of Langerhans, they produce the insulin. So they are producing insulinoma or thing, and the amyloid is produced in the endocrine gland. So 95% to 90% are fibrillary protein, and another 5 to 10% are the non-fibrillary protein or B components. They are the glycosamine glycan, apolipoprotein, and the other proteins. They are under the non-fibrillary protein. They are associated with this amyloid material. So what is the pathogenesis? Normal misfolded protein is formed due to some result. Maybe a normal protein is abnormal or maybe a mutated protein. They are within this layer, they are disintegrated by the proteasome, and outside they are disintegrated by the macrophage. If not disintegrated, they are disintegrated as amyloid. This is the nutshell of pathogenesis of amyloid. Now, air protein, I told this is a maybe idiopathic, maybe a plasma cell dysplasia, maybe a multiple myeloma, or B-cell lymphoma, and they produce enormous amount of immunoglobulin, and if that immunoglobulin is not excessive or not distributed, they are deposited as amyloid like not A type of amyloid. A type, what I told, this is a chronic inflammation they are produced, and these are produced from the liver as SAA by the activation of the IL-1 and IL-6, and they produce this SAA protein. First of all, if it is a partially degraded, fibrillary protein becomes non-fibrillary and insoluble and deposited as AA type. This is a hemodialysis associated protein that is beta 2 microglobulin. Due to the chronic renal failure, due to frequent dialysis, this beta 2 microglobulin are not crossed in dialysis limit as deposited as beta 2 microglobulin. These are the common amyloid material. Pathogenesis, what I told. So pathogenesis normally is a normal protein. It is a folded protein but structurally active. If it is misfolded and is not active and is deposited as non-fibrillary beta-plated sheet configuration and act as an amyloid material within the C state. So pathogenesis in a two heading. One is a normal protein where it is produced in abnormal amount, that is the acquired mutation or maybe a chronic inflammation, or if it is a normal amount, produces a mutated form. So if it is a normal protein in a abnormal amount, it is a form. One is AA type, another is a AA type. And it is a transthyretin, it is a mutated form of protein amyloid. They are deposited as ATTR that I discussed before. So these are the pathogenesis is the thing when how it is formed and when it is formed within the tissue. Now how it classified? So order in us in the short note for each and every time. So you learn this small amount of it. How it is classified? Based on the primary or maybe a secondary. Or it may be based on the extent of deposition. It may be a localized or it may be a systemic, or it may be a systemic or generalized. Or there is a systemic, maybe primary, maybe secondary, maybe hemodialysis associated, or a mutated or hereditary familiar type. It is a systemic one. But it is a localized according to the organ type. It may be a cardiac, that is a senile cardiac, or it may be a senile cerebral, maybe in the stages, or it may be endocrine, that is a localized in the endocrine gland, or it may be any tumor that can produce a amyloid. So you can classify in the exam, maybe localized, maybe systemic. Under localized according to the organ, cerebral, cardiac, hereditary, familial, endocrine, tumor producing thing, and the systemic, it is a maybe primary, maybe secondary, maybe hereditary, or it may be a hemodialysis facility. To write in very short, that it is a very small amount of that as in the as short form or discuss form. But not go in details. Now, if it is a clinical association classification, if we correlate clinically the disease associated with this thing, it may be a generalized or systemic, it may be a localized or it may be a hereditary amyloidosis. In generalized or systemic, it may be primary, we know that is the multiple myeloma transversal dysphasia, or it may be a secondary AA type precursor protein is from the liver SAA and the chronic infection. And in hemodialysis, I told it a beta 2 microglobulin. Amyloid is a beta 2 microglobulin, chronic renal failure, which needs frequent dialysis. If it is a localized one, it is a cardiac localization, maybe a heart localization, maybe endocrine localization, or it may be a tumor one. And hereditary amyloidosis is a hereditary Mediterranean fever, hereditary amyloidosis of polyneuropathy, or it may be a senile amyloidosis. So these are the clinical correlation and classification to correlate with this thing, amyloidosis. So if we ask in the exam, this is classified inertial only, you write. If it is a precursor form, how it is formed, what is the name of that thing, and on the clinical correlation. You can write like this way. Sometimes I ask in the exam, the primary and secondary, how we differentiate between these two? We know primary is the amyloid light chain type, secondary is the amyloid associated protein. Both are some differences. It is a immunoglobulin, disease is different, and stimulus also different. We know from the beginning that our origin is here, another is a different origin by primary and secondary. Due to secondary, due to this information, and the organ also are more or less same, but one staining differences is that if you put the conjugate stain after potassium permanganate, that conjugate stain will persist in primary one, but it is negative potassium permanganate and conjugate stain. Next one, other than metachromatic stain. Metachromatic methyl halide or crystal halide, they produce rose stain. That is the metachromatic stain. Metachromatic stain means that stain, what we are giving that color, it will impart a different color. That is called metachromatic stain. It is a metachromatic stain, methyl halide or crystal halide produce a rose pink color. Now, Asian blue, they produce blue. Colorless blue produce the blue color. Next, the PAS, paratic acid cis reagent, they produce rose pink color. Next, fluorescent stain. If the tissue is treated with the fluorescent color, that is the carbonyl T or carbonyl S, they produce fluorescent color and identify the fluorescent microscope. Why we need? Before that, we don't have so much of instrument or so much of method to identify amyloid. But after that, within the molecular analysis, within the advent of molecular analysis, we can identify by immunohistochemistry or immunostaining, as it is a chemically different. So different chemical analysis you can do immunohistochemistry by particular antigen you can do by different as of antibody for by the chemical nature. Anyway, so these are the things we have to write in the exam. They will ask them write down the staining characteristics of amyloid. So 1, 2, 3, 4, but whatever you know, you write. Okay? This will do for exam. Clear? Now, what is the tumor associated with the amyloidosis? This is a metabolic carcinoma of the thyroid. They produce amyloid. Then the renal cell carcinoma, they also produce. Then Hodgkin disease, Hodgkin lymphoma, and the pancreatic tumor. Then from the islets, they are the tumor, common tumor that associated with amyloid production. See this some clinical feature. So this some down, maybe in the skin, maybe in the GIT, and other the these are just some clinically we can see from the clinician they can suspect that this may be a amyloid deposition. Now, how do we diagnose this case? In suspected case, now we can diagnose by biopsy from the gingiva, from the tongue, from the liver, from the spleen, from the under polarized light, you can confirm. But when it is associated with the AL type or AA type, we need the plasma cell dyscrasia, SCPS, immunoglobulin. If we put the immunoglobulin to identify the myeloma protein, that is the M protein, we can easily diagnose it is a plasma cell dyscrasia, which is a cause amount of immunoglobulin. That also help our diagnosis. Another thing is that if it is an advanced laboratory, they can the protein structure, that is the proteomics of that substance, and the special type of chemical analysis, the type of protein they can identify in a special lab also help our diagnosis. And another, the image that is the using or CT scan or MRI, that we can suspect that organ is so much of enlarged. We can suspect it may be a the diagnosis. Here. Now, what is the study character? If we put that is the iodine may be brown in color, after that we will put direct sulfuric acid, will get blue in color. So, this is above, it is hematoxylinosis state. Below, it is a polarized, it is the component state, which is the red color. Bioreference is active bioreference after amyloid component state. This is the metachromatic cell rose pink in color. This is the fluorescent state, that is the hemoglobin T and hemoglobin S, and below that is the immunostate, a particular type of chemical analysis by antigen-antibody reaction to identify the specific chemical nature of the amyloid. So, hematoxylin, the structural philosophic material component, it is orange to reddish in color and polarized light and apple green white. So we have to, for completion, we have to know definition, their properties, physical character, chemical character, pathogenesis, how it is formed, then the classification, staining character, their identification gross in the different organs, they have gross characteristics and the diagnosis, how they diagnose. So naturally, we have to know this thing for exam purpose. Not go in details and molecular analysis in the footnote of the book. Don't waste time for this. This is a short note only. This written form. So don't waste time so much. You have so many subjects to read. So don't waste time for exam purpose. You read. So what is the take home message? Why we need these things? Why we learn these things? So much things. Because that any organ can be affected by this amyloidosis, and this we have the tools only hematoxylinosis state and component in the lab for their suspicion and diagnosis. Now, why we know? Because the prognosis is very good. If we, as it is a chemically different, if we identify the chemical nature of these things by the molecular analysis, there are some treatment have good prognosis or very treatable. We can identify and we can help the patient for cure or some poor or moderate prognosis for this. This is the nutshell or amyloidosis. Thanks. And so this is a short note for the Don't go in details. Only this heading you follow for exam purpose. Thank you.
This Thursday, assessment session, and the coming two Thursdays, we're going to have an assessment, a written exam time. Don't worry. Don't worry, we'll discuss the questions then and there. So, the next is Thursdays, you're going to have an assessment on cell injury. So, prepare yourself. And for the GOP sessions, which I send in WhatsApp that I'm going to send it later, what I'm telling you right now is we're going to have a seminar. So, the topics would be there for the coming 2 weeks. We're going to have seminars on 4 topics. So, first week means 3 days, 10th, 11th, 12th, and 17th, 18th, 19th. The 2 consecutive weeks, that includes 3 days of the week. Okay, batch A, batch B, batch C. So, your topic would be, first 2 days would be, say, extramedullary hematopoiesis and extramedullary hematopoiesis. Can you hear me? Can you hear me? Hematopoiesis and extramedullary hematopoiesis and anticoagulants. So, that will be on the first 2 days. And the next 2 days, we're going to have seminar on iron metabolism and hemostasis. Now, the reason why we chose you to speak on this topic is you have studied all these topics in first year, right? you have studied iron metabolism in biochemistry, you have studied hematopoiesis in physiology. So you'll be giving seminars, and if necessary, if we have time, because the first year, the second year has been cut short to 1 year from 1.5 years. So we do not have enough time to teach every topic. And because you have studied them, because they are already integrated with biochemistry, vertical integration with biochemistry and physiology, and you have studied them, so you have to present the topics. It's good for you. So it's up to the seers. It's up to the seers to find students who want to lecture on these topics and let the department know. So who is going to take responsibility? Who are the seers? Who is the seer? And our seer. So it's up to you guys. What's your name? Huh? Krishna Bahari. Acha. So it's up to you guys to find out who wants to present the topics and send it to us, to the department. You can send it to me or you can send it to anybody in the department. Is that clear? So what are the topics that you're going to lecture on? The first 2 days?
So can you repeat the topics once more?
Extramedullary hematopoiesis and extramedullary hematopoiesis you have studied in physiology, and next one is anticoagulants. So you have studied all these things. So we are not explaining them because we do not have enough time to lecture. So you better prepare and you tell us. Okay? So you have to present a seminar on this. So these are the 2 topics, and we need at least a few students who is going to lecture on these topics. Okay? From the 3 batches, the first 3 batches. Okay, we need at least 6 or 8 students. Is that clear?
Yes, sir.
So, CRs, you take up the responsibility. It's your responsibility to identify, to find out who is going to give seminars on these topics and let us know. Okay? And remember, assessment, we are going to have an exam kind. Don't get worried. Don't worry. Okay? Clear? Done. Should I write the topic?
Yes, sir. Yes, sir.
So hematopoiesis and extramedullary hematopoiesis. So these are the 3 topics of the first 2 days. The first, next 2 days are writing. Clear? Clinical event occurs that occurs with drug therapy. It may not be related, it might not be related, but you have to report it, and later the experts will analyze whether any causality is
present there or not. Whether the drug is actually causing the disease or not, it is to be decided after reporting and after analysis. Okay, we have various scales for that. I think Banksy already know those scales that you will be learning. So, as for example, you all actually have taken common cold medication, common cold remedies. You have taken have you taken common cold remedies, cetirizine, levocetirizine, right? So these drugs actually, in a case scenario, an old person, like say 65 years of age, have taken previous night anti-cold remedy, and the next morning he met with road traffic accident. So apparently, road traffic accident and the medication is actually not connected. It is superficially it looks like that, but the fact is that actually the antihistaminic agent is very notorious to cause sedation, dizziness, sleepiness. So what is happening there? He is having dizziness while crossing the road, and that is why road traffic accident has been occurred. So if you not report road traffic accident, it is causing because of this antihistaminic, you may miss the adverse drug part, sedation. Right? So this is the reason you have to submit all, and thereafter how much it is connected or how much it is caused by the drug, it will be decided later. So according to severity, ADR can be classified into 4 groups. So here you can see there will be mild, there will be moderate, severe and lethal. So what is the difference between severity? So minor means no treatment is required, no antidote is required, no requirement of hospital admission. Okay. Moderate, what moderate means that you require some amount of treatment and you may have to admit the patient, or the hospitals here already admitted patient might increase by 1 day. Okay, so this is moderate. Now next severe. So severe means permanent damage of any organs. Okay, like for example, you already know, I think painkillers are notorious to cause peptic ulcer disease, ulcer diabetes. So that is a that is a change that is occurring with the drug, and it is present even after stopping the drug. Okay, so that is why that should come under severe. Okay, so intensive treatment is required and life-threatening condition. And lastly, lethal. So mainly lethal means that directly or indirectly it is causing death. The drug therapy is related to the death. Okay. So in various textbooks, one textbook called KDP Party. Okay, so KDP Party, Pharma and various other textbooks which are in the market and commonly used, you will see that the classification of adverse drug reaction are represented in various ways. So this is one of the ways. So it is very easy to remember actually, type A, B, C, D, E, F. Okay. So augmented desired reaction, C continuous, D delayed, E for end of use, and lastly A failure of efficacy. So this is the classification. It is written in Pharma, but in your textbook, like say KD3 party, which I think most of you follow, KD3 party is only having this type A and type B. So augmented reaction, desired reaction. Okay. So this is the classification according along with that examples of the various effects. So we will come one by one to all of them. Okay. So first of all, type A and type B. So what A stands for? A stands for augmented reaction and B stands for desired reaction. So basically, augmented reaction is the extension of the pharmacological effect of the drug. So one drug, like say for example, paracetamol is causing decrease in temperature in case of fever. So if paracetamol is given in a very high dose, there might be a chance that patient is suffering from hypothermia. Basic কাজ হয়ে গেছে, কতটা লাগবে না। So that is coming under augmented or type A reaction. Type B means you have injected penicillin to a person, immediately he is having severe itchiness all over the body and formation of urticaria. So this is the allergy, drug allergy. So this is type B or desired reaction. Now difference between these two, type A and type B. Type A is actually dose related. Means that paracetamol is causing the side effect only because of you are giving it in a high dose. So if you decrease the dose, there will be no such problem. But type B, even penicillin, even 1/10 of the dose is able to produce allergy, easiness. Okay. So that is the reason type A you can use the drug again with cautious dosing. But type B you cannot use the drug anymore to that patient. Okay. So this is the difference. Type B is of course very rare. Type A is very much common. Type A is not a life-threatening situation. You can easily handle that. But type B might be life-threatening. So that is why you will not use the drug again into the patient. Okay. So here you can see examples. So I have already told you. So dryness of mouth, blurring of vision due to atropine. Atropine is one of your anticholinergic agent. You will learn in few days during ANS. And type B, here you can see penicillin causing anaphylactic reaction. Already I think in microbiology or pathology you have heard about anaphylaxis, right? So this thing can occur with penicillin G. So you already know, I think penicillin anaphylaxis is a very life-threatening situation, is an emergency situation. So you cannot again give penicillin G to that patient. So side effect. So side effect and this adverse drug reaction is slightly different. Okay. So here you can see side effect. What is side effect? Side effect is the unavoidable but present, unwanted but often unavoidable extension of pharmacological action. So always it will be the pharmacological action that is occurring. It means that whatever reaction it is going on, we will be easily able to explain it through receptors or enzyme or channel. We can explain it. Okay. And it should be in the therapeutic dose. So that is very important. In the next slide, you will learn about toxic doses, toxicity. So toxicity is actually overdosing. But here you can see therapeutic dose. Okay. So most of the time it is extension of its normal function, normal pharmacological action. So atropine as an anticholinergic, the main actually effect of this atropine is to decrease secretion from glands, be it a sweat gland, salivary gland, anything. So salivary gland, if saliva secretion is decreased, so what will happen? Dry mouth. Okay, so this is nothing but the extension of pharmacological action, but might be different facet of action can occur. হতে পারে ডোজটা এত হাই দেওয়া হয়েছে যে there is another pharmacological action that is supposed to occur higher dose, it is occurring. Like say promethazine. So promethazine is another antiseptic agent. So that antiseptic agent is supposed to be given for treatment of allergic reactions, but because of side effect, because of its latent anticholinergic action, it is having sedation. So this is actually the another part of the pharmacological action of this promethazine drug. Okay. Now, sometimes we exploit the side effects as a therapeutic effect, and we can use it for different indications, different uses. Like say codeine. I don't know whether you have heard about codeine or not. Codeine is one of the very useful drug which is used for dry cough. Okay, so dry cough suppression. Codeine is a very good drug, but the problem is that codeine is a derivative of morphine, opioids. So you know opioids is an addictive agent. So that is why sometimes codeine is abused. That is why we nowadays we do not use codeine that much. But codeine, when it is used for cough, we have seen that codeine is producing some amount of constipation. Okay, because it is morphine derivative, and morphine has a natural effect that can cause constipation. Now the thing is that for traveler's diarrhea, do you know what is traveler's diarrhea? এখানে দিল্লির লোকজন আছে কেউ? দিল্লি থেকে এসেছে? So you have heard the term delivery, right? Actually the foods there is too much spicy and sometimes contaminated with microorganisms lead to diarrhea. আমরা যদি চাই ওখানে গিয়ে খাই রাস্তার খাবার, we will actually may have diarrhea. So those diarrhea is actually called traveler's diarrhea. For traveler's diarrhea, we can use this Coden's constipation property. Diarrhea means what? Loose stool, frequency of stool is increased and consistency is loose. So we can easily give codeine and it will cause decrease in diarrhea. Now, there are some drugs whose side effect actually gives an idea to explore it to develop new drugs. So that is very interesting because as you can see, sulfonamide is one of our first antibiotics, one of the first antibiotics which is actually discovered. Now, sulfonamides, when we use sulfonamides for antimicrobial therapy, we have found that it is able to decrease blood sugar level. Okay, along with that, it might cause lactic acidosis. Okay, so that two property has been utilized to produce another drug, sulfonylurea and carbonic anhydrase inhibitor. Sulfonylurea is one of your very well-known group of oral antidiabetic agent. Okay, and carbonic anhydrase is a diabetic agent. So all these drugs are developed from actually sulfonamides. Okay. Next, toxic effect. So toxic effect is actually occurred because of overdosage. So you have side effect which is occurring at therapeutic dose. You have toxicity which is occurring at overdose or prolonged use. Okay. Now, here you can see toxicity can occur because of multiple reasons. Might be accidental. So you have an elderly person you have prescribed some sedative agent for his or her insomnia, and at night he might take one or two or three or more of those tablets and having toxicity. So it is completely accidental, or it might be homicidal and suicidal. So the person is actually taking the drug knowingly. Now, sometimes it might be absolute, sometimes it may be relative. So the thing is that absolute means you take the drug in high dose, you are getting toxicity. But in some individuals suffering from particular diseases, might be a normal therapeutic dose can actually have toxic effect. Okay, so here you can see gentamicin. Gentamicin is a known actually nephrotoxic agent. So if you give that drug in normal dose in an individual whose actually kidney function is already suppressed, in normal doses it will cause toxicity or renal failure. Okay. Similarly, paracetamol, you have given paracetamol in a patient of liver toxicity or hepatitis. Suddenly, patient may go into fulminant hepatitis. Okay, and it is a life-threatening situation. So again, those drugs with that dose will not produce any side effect or any toxicity in other person, but only in those persons because they have already suppressed kidney and liver function. So, what are the examples? So, functional alteration can occur. So, here you can see toxicity effects of atropine may cause delirium. Will you actually, if you are familiar with the delirium, you have heard the term before, delirium. Delirium means that, like say a person is saying he is the Prime Minister of India. Okay, so this is called delirium. It is a false belief. Now, drug-induced tissue damage, here you can see paracetamol, I have already said that example. Extension of therapeutic effect. So, normally barbiturate is a CNS suppressant drug used for epilepsy, and these drugs, if it is given very high dose, you will find out that there is extension of CNS suppression which ultimately leads to coma. Okay. Another reaction, so morphine may cause respiratory failure because morphine also is actually suppressing the respiratory center present in the CNS. So that is why you are getting respiratory failure. So poisoning. So that is the offshoot of toxicity, that is poisoning. So every drug, you always remember that thing, every drug is a poison. It only the dose, the therapeutic dose, which is actually differentiating whether it is a drug or whether it is a toxin. So most of the time, or almost always, if we do not require to give any medication in a person, we should not prescribe it. Okay, because it will cause something in the body. So this is called poisoning. So substance which endangers life by interrupting or disrupting one or more vital functions of the body. So can you name the vital functions? Ki ache vital functions? What are the vital functions or signs of life? So according to you, what are the most important organs in our body? Brain, okay, and heart. Another and any other thing? Liver, kidney. A patient can survive with hepatitis. So there is another organ which is very important, that is lungs. Yes. So vital functions means heartbeat, respiration, and consciousness. Okay. So those three are actually now the forensic medicine starts. So in the forensic medicine, you will find that they will taught you whether when we actually know that the person is dead. It's very difficult thing to judge. Okay, so you have to examine for all these three vital functions whether they are present or not. Okay, so it is the dose which actually distinguishes a drug from a poison. So dosing is very much important, and that's why what we expect from you that you always write the correct dose. But I know that this is very difficult for you in the second year. But you do not write anything absurd. Like say a drug has to be given 0.5 milligram per day. You have written 5 milligram per day. So that is a huge difference. You do not have to write. If you do not know the dose, it is okay, completely fine. You do not write those absurd things. Okay. What are the negative content? So what is the management of poisoning? First of all, poisoning, most of the poisoning, we do not have antidote for all of them. So we have to follow a general guidelines or general outline of management to every poisons. Okay. So first of all, we go for resuscitation and maintenance of vital functions because that is important. Because vital functions if interrupted, then the patient might not survive. So that is the reason you have to go for the vital functions. So what are those? We actually remember it from our college days as ABC. So airway. So you have to actually ensure the patient has got a patent airway. অনেক সময় কি হয় if the patient become unconscious immediately what happens the tongue falls back over the epiglottis and that is the reason your airway is getting blocked. Or in case of anaphylactic reaction you have huge edema obstructing the larynx. Okay, so that is the reason you have to ensure that the airway is patent, and for that you might have to intubate the patient or you might have to go for tracheostomy. Okay. Now breathing. So you have to actually ensure breathing in that patient. So it might be requiring oxygen inhalation. You have to give it. Might be the patient need to be given assisted ventilation or mechanical ventilation. You have to give it. Okay. Next, circulation. So circulation, there might be fall in blood pressure. You might not actually palpate the pulses. So you have to give some drugs so that the blood pressure rises. If it is a hemorrhagic condition, you might have to go for blood transfusion and all that. Okay. Then comes the supportive treatment. Supportive treatment means the patient is suffering from high temperature. Fever is there. Most of the poisons may cause fever. So you have to make the patient lose body temperature if there is fever. So you might go for tepid sponging, cool bath, or you can go for paracetamol or any other antibiotic agent. Blood sugar. So blood sugar you have to control whether it might be a high blood sugar or low blood sugar. So you have to treat it accordingly. So low blood sugar, what drug you will prescribe? Low blood sugar. Low blood sugar, hypoglycemia. So what drug you will prescribe to that patient? Yes, glucagon. If hypoglycemia, hyperglycemia is metformin. Glucagon is right. I am not denying your answer, but the thing is that more simpler drug is available in our hand, even in our households. Yes, sugar. Glucon-D. And if you are in hospital wards, you will give dextrose solution, 5% dextrose, 25%. So dextrose solution you can read. And if there is convulsion or seizure, you might go for anticonvulsant, antiepileptic agents. Okay. Now, termination of exposure. So that is very important. Termination of exposure. So a patient is actually have an insecticide poisoning. Okay. And these insecticides are very much lipid soluble. So it can actually enter into the body through the intact skin also. So that is why what you will do to terminate the exposure is to wash the area where insecticide is there. If it is on the cloth, you have to actually remove that cloth and give fresh cloth to the patient. Okay. If it is inhalational poison, so you have to shift the patient into a fresh environment. Okay. অনেক সময় দেখবে ইমার্জেন্সিতে পেশেন্ট ঢুকছে, you will find that all the students gather around him. So that is not good for patient suffering from inhalational poisoning because he needs fresh air. Okay, so that is why you have to admit the patient and ensure that the person gets the fresh air. Now, prevention of absorption of the ingested poison, that is also very important. So mostly poisoning can occur by ingestion of something like say insecticide or any other thing. So what you should do, you immediately the patient comes, if comes within 4 hours, you immediately will try for induced vomiting. Okay, and if vomiting is not there, gastric lavage you can do, but there are certain situations where you cannot go for that. Which of those situations? First of all, you have a poisoning occurring because of cardiac CNS depressant agent. So CNS is already depressed. So how will you induce vomiting? Will not occur. Or the patient is poisoned by some strong acid or alkali. So what will happen if you induce vomiting? It will again come back through the esophagus, oral cavity. So it will cause burn in those areas. So you do not go for that. Kerosene poisoning. Kerosene has a very low viscosity. So when it is vomited out, some amount of kerosene is going inside your lung. So it is causing pneumonia, aspiration pneumonia. So the situation getting much worse. Okay. And also, if the patient has come to your clinic or emergency after several hours of taking the drug, already that passed through the stomach, absorbed or okay. So you can go for that. Achha. So have you ever seen in emergency doctors giving stomach wash? So the thing is that stomach wash, you have to actually insert a Ryle's tube or nasogastric tube, and thereafter you have to make wash. It means that you administer some water, distilled water, and again suck it out. Okay. You can add some indicators with it, like say potassium permanganate. You can add with that, or you can add some absorbing agent, like say charcoal. You can add. Next, hastening elimination. So, what are the routes of elimination? Already well achieved. Pharmacokinetics. What are the routes of elimination? So, there are two routes mainly: hepatic route and kidney renal route. Now, for hepatic route, you cannot do anything. Drugs which are maximally eliminated from liver, you cannot do anything. Okay. But for renal route, what you can do? You can go for hemodialysis. Dialysis for bar. Previously, one procedure is there that is called forced dialysis. Forced dialysis means you give saline, IV infusion, and thereafter you administer diuretics. But the problem is that with that therapy is that patient often goes into dehydration and electrolyte imbalance. So again, situation becomes much worse. So that is why we will not do that now. So we will stick with hemodialysis. So what are the drugs? Phenobarbital, carbamazepine, valproate, lithium, salicylate, theophylline. Most of the drugs are CNS drugs. Okay. So chances of toxicity or overdosing is much more higher in them. Next, antidote therapy. So this part is actually not available for every poison, every drug, every chemical substances which can cause poison. Okay, so this is a list. I will not go into the details. You will be learning with each and every drug which we learn the specific antidote. Okay, and it is good for your MCQ. I think you have to one group you have to give examination on Thursday, right? So this is good for MCQ. Next is intolerance. So intolerance might be the term you have already heard, I think. So it is just basically the opposite of tolerance. I don't know in the pharmacodynamics you have learned the tolerance or not. Tolerance means that you have given a drug and after some doses the drug is not working. The drug is not producing its effective pharmacological action. Intolerance is that a single dose of drug is producing so much amount of pharmacological action that you cannot use the drug again. Okay, so adverse reactions are occurring. So you see the examples. Chloroquine is a very common drug which is used for chloroquine. Yes. Rheumatoid arthritis, that is basically hydroxychloroquine. Okay, chloroquine is also there, but what is the main drug of choice? Yes. Malaria, yes. So for malaria you give chloroquine. Now chloroquine has a toxic effect or side effect I should say, that is vomiting, which occurs person taking chloroquine in a very high amount, loading dose. Okay. But here some patients after single dose of chloroquine might vomit. So in that chloroquine is not going to be very effective. You have to think about other antimalarial agents that you can give. Next is idiosyncrasy. So whatever we have talked until now, these are occurring as extension of pharmacological action. But this idiosyncrasy is not the pharmacological action. It is occurring a completely different. It is having different set of pharmacological action. Okay. So basically, idiosyncrasy, the drug is reacting the genotype of the patient. So all patients will not get this type of reaction. Only very few patients will get this type of reaction. So this is idiosyncrasy. We call it type B reaction or desire. And it is unpredictable. We cannot estimate which patient will have that and which patient will not. So we have to be very careful for preventing these reactions, idiosyncrasy. Okay. So here you can see example. D6PD deficiency can cause primaquine. Primaquine is an antimalarial agent which has got oxidative function. Okay, so if G6PD deficiency is there, what will happen? RBC cannot handle that much of free radicals or oxidative reactions, and RBC will lyse, and there will be hemolysis, and you will find anemia. So not only primaquine, same reaction goes for salicylates and sulfonamides. Salicylate means your aspirin. Aspirin is so you are familiar with aspirin. Okay, so this is idiosyncrasy. Now we go for drug allergy. So drug allergy is hypersensitivity. Another very common term or sound-alike term is supersensitivity. So hypersensitivity and supersensitivity are not same. They are different. Hypersensitivity means that they are producing some reaction. Supersensitivity means that they are producing their therapeutic effect at a very small dose. So that is called supersensitivity in some individuals. So this drug allergy is actually the features are not alike the drug's pharmacological action. It is more alike allergic reactions which are occurring because of foods or dusts. Okay, so this is drug allergy. So what are the features when actually you consider this thing? So there are some features that you need to identify. One or more of these features will be present there. So unrelated pharmacodynamic action. You have taken like say paracetamol and you are having itching all over your body. So it is not the pharmacological action. It is not supposed to do by the paracetamol, but it is still doing that. So this is actually drug allergy. Manifestation similar to food and dust allergies. So I have already told you. Severity is unrelated to the dose. Means that even a small dose can produce. Just that like type B reactions, I have already told you. Only in few recipients, not in majority of individuals, and it might be life-threatening situation. Prior sensitization should be present. Now the thing is that sometimes sensitization occurs unknowingly. So when you ask for history of prior exposure, you might not find that because the person is already sensitized unknowingly. So you cannot get that. Lastly, positive de-challenge and re-challenge test. So what is de-challenge and what is re-challenge? Can you guess? De-challenge is removal. Yes, exactly. Yes. So the reaction when we remove the drug, it is subsided. But again we introduce the drug, the reaction again starts. So that is your de-challenge. So drug allergy, we actually have three types of drug allergy. Uh, from drugs point of view, we will talk in pharmacology class, but you will learn about the actually elaborate description of this type 1, type 2, type 3, and type 4 reaction in microbiology and immunology. Okay? So type 1, 2, 3 are actually humoral immunity. It is based on humoral immunity. Type 4 is cell-mediated immunity. So type 1 antigen antibody reaction or type 1 drug hypersensitivity reaction is actually the anaphylactic reaction. Means that you have a drug which is allergic to a particular person. You have given the drug initially. The person will not show any symptoms. Only there will be production of reagenic antibody, means IgE antibody. Okay. Now this IgE antibody, I think you have heard about mast cells in physiology and basophils. So these mast cells and basophils have got attachment sites for this IgE antibody. Okay. Now next time you administer the same drug, what will happen? The drug will directly bind with the IgE antibody present over the mast cell and basophil. And what it will cause? It will cause release of inflammatory mediators, mainly histamine from the mast cell, degranulation. Okay, and you will have severe allergic reaction. Your lip is going to swell. There will be palpitation. You might have breathing troubles. Okay, and there might be urticaria. So this is a life-threatening situation. You have to give some treatment immediately. So for anaphylaxis, what you will give just by guess. কোন জিনিসটা দেবে anaphylaxis? Cause is histamine. Yes, antihistaminics you will give. But the thing is that before antihistaminics, you might have to give adrenaline. Okay, because you remember adrenaline and histamine. What are those? Physiological antagonism. They are doing opposite actions but acting on different receptors. Okay, so that is why adrenaline will be the drug of choice, and you have to give antihistaminics as well. Okay, so example, penicillin-induced anaphylaxis. Next time you visit any ward or ICU, you will always look for penicillin glucophage is very commonly given to patient. You look for the treatment sheet. You will find that there the order is given like penicillin such and such dose after proper skin test, appropriate skin test. The skin test is done only to actually see whether they are producing any allergic reaction, anaphylaxis or not. তাহলে আমরা দেব না, ঠিক আছে? Type 2 reaction, or it is called cytolytic reaction. Again, it is a kind of humoral immunity mediated reaction. So what is happening here? Drugs along with some tissue component, tissue proteins, they are acting as antigen. Okay, and whenever these antigen and antibody reactions is there with the IgM IgG antibodies, you will find that there will be release of certain mediators which will activate the complement system, and this complement system is actually causing destruction of the tissues, cytolysis. Okay, so that is why it is termed as cytolytic reaction. Now check the onset time, 5 to 12 hours, but it is type 1 is only minutes to hours, very fast, but here it is 5 to 12 hours that can occur. So examples here you can see thrombocytopenia, granulocytopenia, aplastic anemia, so all can occur with type 2 reaction. So again, penicillin, methyl-dopa is a anti-hypertensive agent given to pregnant women, can cause actually cytolytic reaction. Type 3 Arthas reaction. So type 3 is actually, you see the onset time, it is 72 hours, much more prolonged. Okay, so here again antigen antibody reaction is there, but here they do not require any tissue protein. Here antigen antibody reaction occurs into the circulation itself, and thereafter it is getting precipitated over endothelial cells and causing reaction. Okay, so this is R plus reaction. So you can see that example, Stevens-Johnson syndrome. Have you ever seen Stevens-Johnson syndrome? If you go into the ward, you will find 1 or 2 cases of Stevens-Johnson syndrome. It is the patient looks like completely burnt patient. উপরে স্কিনটা এপিডার্মিসটা পুরো destroyed হয়ে যায়. Okay, so that is Stevens-Johnson syndrome, which is occurring because of some drug allergy, drug-induced reaction. And also Stevens-Johnson syndrome management is same as that of burnt patients. Okay. Lastly, delayed hypersensitivity reaction. So type 4 reaction is a cell-mediated immune reaction. So your T lymphocytes are getting activated by plasma cells. Okay, and thereafter you are having this reaction. So for activation of T lymphocyte, you require some time, and that is why it is called delayed hypersensitivity reaction, because onset is 2 to 3 days. Okay, so allergy can occur even 2 to 3 days after therapy. Okay, so that you should always keep in mind. You cannot rule out the possibility of a drug allergy just because it is happening after 3 or 4 days. You cannot do that. Okay, sometimes features are very similar. Like one example I can give, amlodipine, amlo 5, that is your what do you call it? That is anti-hypertensive agent most frequently used in our Indian population. Those drugs are notorious to cause ankle edema. Okay, now if you have allergic reaction, patient might have swelling also. So how you can differentiate those things? You cannot differentiate. So what precautionary measure you can do? If it is ankle edema occurring because of a side effect of amlodipine, you decrease the dose, it is okay. But for allergy, you have to stop the drug therapy. So you go with allergy and stop the drug therapy. You do not decrease the dose. So now we go into a very important topic for your age, actually, not for curriculum purpose, but also you have to learn all those things. So drug dependence. So drug dependence might be psychological or it might be physical. Okay. So drug dependence means that a patient is a person, or patient I should not say, a person is taking a particular drug and he is thinking that that particular drug, without that particular drug, I will not survive. Okay. My bodily functions will not function. You ask a patient who is addicted to smoking, you will get the history that you will tell, if I stop smoking, I cannot sleep. But smoking has nothing to do with sleeping. Okay. So what is drug dependence? Drug dependence is actually occurred to drugs which are capable of altering moods and feelings. So this is very important for you people, because by the time you reach 4th year, final year, you become so much depressed and you go sometimes into this path of dependence. Okay, so always make sure that you always stay away from this. Okay, so what are the effects? Why we actually go into that dependence? Because we have euphoria, social actually adjustment, withdrawal from the reality. So all these things actually required in 4th year, final year. Okay, the study actually pressure is very high and you are not coping up with all those studies, and you are actually thinking that you might not be able to pass the exam. So that is the reason. But it is nothing to afraid of. All medical students, all doctors have gone through the same pathway. Okay, so if they can pass, you can also pass. You have some credits, that is why you are here. So you can do that. Okay, without help of a drug. So now there are 2 types of drug dependence. You have physical dependence and you have psychological dependence. So physical dependence is actually a condition where because of repeated drug administration, there is alteration of normal physiology and you cannot actually maintain the physiological equilibrium in absence of the drug. So there is a need to take the drug again and again and again. Okay, and that is why when you stop the drug therapy, you will find some symptoms will be there, like say withdrawal syndrome. Patient is taking alcohol, binge eating, binge drinking alcohol. Suddenly in the morning when alcohol concentrations are low, you will get hangover. That is also a kind of withdrawal. Okay. Disulfiram, yes, exactly. Disulfiram is causing that withdrawal effect, and that is why what is happening? Actually, disulfiram mechanism is different, but the effects are same. Okay. Yes, disulfiram, what it is doing, it is producing from ethanol aldehyde compound and acids, and that is the reason you are getting symptoms. Okay, so this is the toxic effect. But these toxic effects are similar to that of tannin because your body is not getting alcohol. Okay. Now, what are the drugs that can cause that physiological dependence? We have barbiturates, alcohol, and benzodiazepines is a sedative agent. Okay. Psychological dependence or addiction. So here there is no dependence. There is no physiological adaptation is there. But patient is thinking that I have to take the drug. Okay. So that is actually psychological dependence, or we'll call it addiction. So cocaine, morphine, LSD, cannabis, these are all actually addiction. Okay, not dependence. And another very important point that is characteristic of this addiction is the drug-seeking behavior or craving for the drug. Okay, so drug-seeking behavior, if it is present, we can call it addiction. Okay, and you will be astonished to see some drugs are dependence. They can produce dependence, but they do not produce addiction. Like say nalorphine. Nalorphine is the drug which is used for opioid withdrawal. A person is actually addicted with opioid, we will give nalorphine to actually withdraw the drug. So nalorphine produces dependence, but there is no addiction. Okay. Now there are few terms related to this drug dependence. We have reinforcement. So reinforcement is the capability of the drug to produce effect to the liking of the person who is taking the drug. So that is the actually driving effect. That is why we are taking the drug repeatedly. Okay. So opioid, cocaine, these are actually having reinforcement. So next is drug abuse. Drug abuse is just like addiction, but the thing is that here the intensity is much more low. So normal drugs like say laxatives, most elderly persons are actually abusing laxatives. So they will tell you that without laxatives, I cannot actually constipation occurs. Okay. Drug habituation. So tea, coffee, we are all habituated with that. Mutagenicity, carcinogenicity. So mutagenicity, as the name suggests, it is causing some mutation in the body, and carcinogenicity is producing cancer. So mutagenicity, if the mutation is only limited to a particular generation, there is no heritable incidence, then it is not producing cancer, but it might produce cancer if it is heritable. Okay. So example here you can see estrogen can cause endometrial carcinoma. You have anti-cancer agent, they can actually also cause malignancy. Okay, and oral contraceptive pills, so they can cause CA cervix and breast carcinoma. Drug withdrawal reaction, so you will be learning ANS, and in the ANS you will find some drugs that they cannot be actually stopped immediately. They have to taper down. Okay, slowly decrease the dose. So one of them is the beta blocker propranolol, and again another is your corticosteroids. Okay. So if you stop steroids suddenly, you will have adrenal insufficiency. Okay. So and lastly, iatrogenic drugs. So this is the physician causing the disease. Okay. So drug-induced disease. So you have NSAIDs, painkiller. I have already given the example. So that is causing peptic ulcer. So that peptic ulcer is not present in that person, but only giving NSAID for a prolonged period of time, we are having this effect. Photosensitivity and photoallergy and phototoxicity. So this is occurring because of UV rays. Okay. So what is the difference between this photoallergy and phototoxicity? So here you can see phototoxicity is nothing immunological. কোনো immunology কিন্তু এখানে involvement নেই. What is happening? Drug and metabolites are accumulating in the skin. You go outside in the sunlight, UV rays fall upon that, and it is causing chemical reaction. or pharmacology reaction and you are having symptoms or signs. But for autoallergy, there is antigen-antibody reaction with the drug and metabolites, and that is activated by these UV rays, and that is why you are getting symptoms. So here you can see tetracycline, sulfonamide, griseofulvin. So these are the drugs which are photosensitive. So how do you treat a patient who is having this photosensitivity reaction? So what you have to do? You have to ask the patient to stop the drug therapy first. If it is not an option, if you cannot stop the drug therapy, what you can do? You can ask the patient to cover as much as possible of the so that sunlight is not exposed. Sunlight actually is not falling upon the skin. Okay. You can ask the patient to use calamine lotion, emollients, okay, antiseptic agents, and also you can go for anti-burn therapy also. Burning is also there. So we are actually on the last part of our today's class. So this is called teratogenicity. Can you actually identify this thing? So this is actually a baby monster. Okay. So teratogenicity literally means to create monster, to give rise monster. Okay. So this is actually it looks like, and in reality it looks like this. Okay. So this is a baby who is suffering from hypomelia or seal baby syndrome. So you can see here the hands are directly attached to the shoulder guard. There is no humerus, radius, ulna. There is nothing like that. And here you can see the legs are directly attached to the pelvic guard. There is no femur, no humerus, no TV. So this is hypomelia, which is actually the starting point where we have actually learned that in pregnant women there are actually some drugs which we cannot prescribe. Okay. So basically, you have heard about blood-brain barrier. Similarly, there is a placental barrier there, which is separating the maternal circulation and the placental circulation, fetal circulation. But the thing is that that particular barrier is not very strict. It is having fenestrations large enough to allow some drugs to pass, and every drug will have some effect over the fetus. It might be less or it might be more, but it is there. So in pregnancy, what is the principle we will follow? We will avoid as much as drug therapy as possible. Okay, we will give iron folic acid tablet, that is okay, but we will not go into other drugs. As much as possible, lifestyle modification maybe we do. So teratogenicity, it is actually the term is there because of the thalidomide disaster. So thalidomide is a drug which is a drug very effective in morning sickness. First trimester of pregnancy, you know, morning sickness is there. So morning sickness, thalidomide has been prescribed. European countries have used it very rampantly, and that is why this hypomelia or seal baby syndrome is very much common to Germany and other European countries. But FDA actually do not allow marketing of this drug in America, and that is why in America there is no thalidomide disaster. So toxicity, embryology have already actually gone through, I think, during anatomy, and this there are for pharmacological purpose. We divide this into 3 parts. First of all, first 17 days, there if you take any teratogenic drug, it will actually go unnoticed. Means that the pregnancy will be lost, there will be abortion, but it is completely going unnoticed. Next, from 18 to 55 days, so this is the period of organogenesis, where different organs are developed in fetus. Now the thing is that when you give teratogenic drug in this time, you will find some anomaly that is occurring. Okay. Lastly, we have growth and developmental stage, so that is 56 days onward. Okay. So any teratogenic drug will hamper the development and functional status of an organ. So you can find it in say premature closure of ductus arteriosus. I think you have already know that biochemistry or anatomical correspondence, patent ductus arteriosus. ACE inhibitor, this is a drug. Often what happens, patient in rural areas might be suffering from hypertension before pregnancy, taking ACE inhibitor as anti-hypertensive agent. They actually do not understand that they are pregnant. So when they come for checkup, already 55 days are over. So might get hypoplasia of lung and kidney. So lungs are completely not developed, kidneys having defect. Now always remember that apart from these drugs, আমি বললাম যে অ্যানাটমিতে তোমরা নিশ্চয়ই পেটেন্ট ডাক্তার সার্ভিসেস করেছো, আমি সেটাই বললাম। Yes, prostaglandins is actually patent doctor services. It is caused by the actually prostaglandins. So if you give NSAIDs, what will happen? Doctor services is going to close. Okay, but the thing is that this is occurring in 56 days of pregnancy, right? So what will happen if doctor services is closed? The fetus is not getting blood adequately, because this is the part where the mixing is going on. Lung is not functional in them. So 1979 FDA is actually divided these five actually category A, B, C, D and X. A means you can give the drug, X means you cannot give the drug. But luckily for you, this is obsolete now. So in our times, even 2 or 3 years before, this comes as a very important actually question in prof examination. But now I think it is not will be given to you. Okay, so now the system is PLLR, pregnancy and lactation leveling final rule. So PLLR actually you have to write down what is the effect, what is the all the teratogenic effect is there on the drug levels, promotional literature. You have to write it down. Okay, so this is the risk category. So examples of some teratogenic drug. So among them, alcohol you have to learn, because alcohol, it is very much common practice in urban areas that they are pregnant women also is taking alcohol, and that is why ending up with following actually outcome in the fetus. So you always discourage pregnant women from taking alcohol. Okay, and also thalidomide, you already know, popomelia and multiple part defects. So warfarin, you have nose, eye, hand defects, growth retardation. You have phenytoin, fetal hydantoin syndrome bola hocche etake. So cleft lip, cleft palate, microcephaly. Because phenytoin is the drug which is given for epilepsy, and epilepsy actually if you change the drug suddenly, there is almost always there will be a breakout actually episode of epilepsy, which is by the way is not very good for the fetus and the mother. Okay, so thank you.